Okay, can everybody hear me?
Yes, we hear you, Dr. Simone.
Okay, great. Well, good afternoon, everybody. I'm Dr. Simone, Jessica Simone from Windsor Dermatology. It's such a pleasure for me to give this talk today on alopecia or hair loss, as actually my first exposure to dermatology was being a patient with alopecia myself at a young age. And so subsequently, I just found myself as a patient wanting to learn as much as possible as I could on the topic. And when I was in med school, I actually took off a year to do research, basic science research at University of Miami. And I did research on alopecia areata and chemotherapy-induced alopecia. And that was extremely rewarding. I learned a lot, and it's just such an honor today to be able to continue to explore this niche and this passion of mine as a practicing dermatology. So I'm honored to not only practice and help patients with this condition, but it's great to be able to teach you about this today. I'm just going to right here. So alopecia is another term for hair loss, and it is extremely distressing and underappreciated. It's to the point where it severely affects one's self-esteem and confidence on a daily basis. And as a personal, I can tell you from personal experience as a patient, it really affected, from me waking up in the morning, hiding the bald spots. I actually was diagnosed with alopecia areata as a teenager, and I spent a lot of time in the morning styling my hair in a way that would cover these bald spots, sometimes even using powder to hide that. And so I understand that anyone who's going through this puts a tremendous effort into hiding this, and there's a lot of shame, and so it's not surprising that there's multiple studies showing lowered self-esteem and decreased confidence with this condition. It's so, I mean, to the effect that it's believable that it's so distressing, because one of the most common or one of the most dreaded side effects of chemotherapy is alopecia. So that just goes to show how distressing this is. And it's no surprise that there's a multi-billion-dollar industry focusing on hair restoration because it's such a huge issue. Now, I can't go into talking about different types of hair loss without going into the hair cycle. And I'm not going to get too complicated, but just enough to know that we all have different phases or stages of the hair cycle. So the first one is the growth phase and the anagen phase. And usually in normal settings, it usually lasts 2 to 6 years, active growth where the hair follicle is actively growing. Catagen is a regression phase, meaning that the hair follicle stops growing. It's basically going into this, getting ready to go into this resting phase, telogen phase. And when you're in this telogen phase, you're entering a resting phase that lasts, usually 3 to 5 months, but then, the hairs start to shed, and this cycle starts over again. Normally, 85 to 90% of hair follicles are in this anagen growth phase. And 10 to 15% are in this resting phase. With certain types of alopecia or hair loss, that ratio can be affected. And I'll go into what type of hair losses can be affected by this in the next few slides. So alopecia, I get this question all the time by my patients. They're like, oh my gosh, so do I have alopecia? Well, alopecia is just an umbrella term. It's a general, non-specific term for hair loss, and there's different types of hair loss. So what we're going to focus today is on the non-scarring types of hair loss, meaning that your hair is able to grow back if given the opportunity. And so the most common types of non-scarring alopecia are alopecia areata, which is what I was personally diagnosed with at a young age. And that's when your hair follicles are targeted by immune system. That's an autoimmune process. We'll go into that in more detail. Telogen effluvium, that's when we're shedding a lot of hair. Androgenetic alopecia, which is female pattern, male pattern hair loss. And then there's scarring. Scarring hair loss is much more challenging because it will eventually progress to scarring to the point where you cannot grow hair anymore in that affected area. So the common type of scarring alopecia is actually a condition called lichen planopilaris. More specifically and more common, something called frontal fibrosing alopecia. So just to give you, it's this picture here. That's one example of frontal fibrosing alopecia, and we'll talk about that more in a second. Traction alopecia, we see this a lot in African American patients or people who love to do those really tight hairstyles. As a child, I can't even tell you the amount of times I used to run track and put my hair in this tight ponytail, and everybody first diagnosed me with this because they assumed that my hair loss was from the traction. But we do commonly see this, and it is from tight hairstyles. Then there's another condition called central cicatricial centrifugal alopecia. It's a mouthful. I just call it CCCA. And it's this one here. Historically, it's been associated with hot comb use in the African American population, but we see it with different types of traumatic hairstyle practices. And it's progressive and very difficult to treat. And actually, treatment aims at stabilization. So we want to make sure we don't lose more hair. So I'm just going to briefly go through the most common type of scarring hair loss or alopecia called frontal fibrosing alopecia. Usually we see this in postmenopausal women. Actually, now more and more we're finding different risk factors for this condition. Interestingly, more recently, we've been seeing that even use of certain, and this is not extensively studied, but this is early, data that we're gathering, that we're seeing people who like to put sunscreen in their scalp. Certain types of sunscreen can actually be a trigger. And I'm not saying that it's not safe to apply sunscreen by any means. Also cosmetic products as well. But, there are certain triggers that we notice that could be occurring in this condition. Another trigger is hair transplantation, or another risk factor. Clinically, we see, or what you would see is a frontal hairline recession. So basically you see that your hairline is actually moving back. On the sides and on the front, we're seeing it's starting further back. And some people might start to see a lone hair growing out of the front here. It's a very specific sign of this condition. A lot of patients will also complain of itchy red scalp, loss of eyebrow, eyelashes, and body hair as well. This is really difficult to treat. It is a type of scarring hair loss. So the goal is to stabilize and slow progression. There's a lot of treatments out there, not one good treatment. My favorite personally is to do an antibiotic, doxycycline, and that calms down the inflammation. So it helps slow down that progression. Also, we like to do steroid injections on the hairline, and that helps a little bit, especially to calm down that inflammation. Topical steroids or anti-inflammatories such as Protopic, and these are things you could just put on the surface of the scalp. Oral Plaquenil, there's been a lot of talk about hydroxychloroquine, which, initially in the beginning of the pandemic, we thought that was the cure-all for COVID, which it turns out to not be, but that is a treatment for this condition. Although it's tough because there's a lot of blood work involved and frequent monitoring of blood work. Finasteride, also known as Propecia, and Dutasteride are also some agents that can be used with this. Topical Minoxidil as well. And then we will talk about the utility of frontal fibrosing alopecia with PRP. We'll definitely gloss over that at the end of this presentation. So again, alopecia areata, this is now I'm going into the non-scarring alopecia, meaning that the hair has a potential to regrow. This is an autoimmune disease. So just to give you, normally we all know that our immune system is supposed to target bacteria and viruses that come in, and your body's supposed to recognize these as foreign. Well, the body's also supposed to not recognize the hair follicle because it's part of our body. So we only recognize foreign, foreign things like invaders. So this is when your body sees your hair follicle, your growing anagen hair follicle, as an invader, and it starts to target these hair follicles and resulting in patchy bald spots. Now, it is more unusual to see a type of alopecia areata, which you can see diffuse loss, and that's called alopecia areata incognito, but you can see both patches and diffuse hair loss. Some people lose all of their eyelashes and all of their eyebrows and hair, and that's called alopecia universalis. There's a plethora of treatments. Again, hair loss is very difficult. It's not, what works for one person might not work for the other. Commonly for the patchy areas, we do steroid injections, Kenalog injections. We do topical steroids, especially in children, we tend to use that a lot. Immunosuppressants, you can use like steroids, like prednisone or methotrexate or Xeljanz, a new medication. And then topical immunotherapy, which is basically when you trick your immune system. So when you put something that's really irritating on your scalp, and that induces an allergic response, it becomes really inflamed, and it acts sort of like a distraction from your body saying, hey, it's a different immune response, so we should, start having this allergic immune response, so we're no longer trying to target our hair follicles. None of these work extraordinarily well, and sometimes it's just trial and error. The next very, very common non-scarring type of hair loss is called telogen effluvium. I've been seeing this so much during the pandemic. So there's numerous causes of telogen effluvium. And if you remember us discussing the hair cycle, like I said, normally 90% of your hair follicles are in this growing phase and 10% are in this telogen phase. So when you have some sort of trigger, whether it be physiological, psychological, or medical, and we'll go into that in more details, that can reverse the ratio of the hair follicles. So you have a greater amount of hair follicles are in that resting shedding phase and for a longer amount of time. Hence that's what causes this, all this shedding to come out all at once. So the different causes of that could be physiological, such as recent hospitalization, recent surgery, of course, recent COVID infection. We've been seeing that a lot. Psychological, pandemic, school, work, hormonal, for all us mommies out there, when we lose, it's not uncommon after pregnancy, a few months later, to start shedding excessive amount of hair. And most of us start to freak out at that time. I know I did. And this is what's going on. It's that rapid change of hormones causing that, the hair to shed. Medications, certainly, change of medications, other medical conditions like anemia, iron deficiency anemia, thyroid abnormalities, vitamin D deficiency is huge. And most of us are vitamin D deficient, especially in the Northeast. So all these things can trigger this massive shedding. And it's interesting because when a patient comes in and they're like, doc, I'm shedding like crazy. I'm getting stressed because I'm clogging the drain and my hair, clumps of hair are coming out. And my first question is, well, it's hard to count, but it's normal to shed up to 100 hairs per day. So if we're shedding more than that, and what I do on my exam is that I look for, it's called a hair pull test. So hairs that could come out easily when we pull it. I'm not trying to be mean. I'm just trying to see if hairs are coming out when I gently pull it. And what we would see clinically, I always ask a patient, because everything is relative. Most people I know have thicker hair than I do. So when I ask a patient, the worst thing you could do is say your hair looks fine. Well, everybody knows everybody knows what their own baseline is. So I ask the patient, well, is your ponytail thinner? Do you notice a big difference throughout your whole scalp, like diffuse thinning? And they'll usually say yes. And that, of course, that's shedding. So what we normally try to do is rule out any medical causes. One thing I forgot to mention is being on any restrictive diets, vegans, again, we can see that massive telogen effluvium. So the workup, like I said, we do some labs. Treatment depends on what is actually the cause. So if it's iron deficiency, we give you iron tablets. I like to recommend prenatal vitamins in general, just because we know that high amounts of vitamin A can cause hair loss. That's a side effect. So I like to stay away from, and it's interesting, a lot of these supplements, that you buy in these nutritional stores or you order online, they have high amounts of vitamin A, which doesn't make sense to me. So I tell people to do prenatal vitamins. They contain a good amount of iron, but low amount of vitamin A because it's toxic to the fetus. So we want to keep those vitamin A levels low. And a lot of people say, doc, what could I do? I'm desperate. What can we do? And this is the hardest thing, because I've experienced it myself. It's tincture of time is the treatment. So it's like, make sure we rule out any medical causes. We take those prenatal vitamins, just give it time, give it 6 months. Now, PRP can help with this, but we'll talk about that later on. The other thing, melatonin in some preliminary studies have been shown to promote hair growth. So sometimes I'll recommend, if we're not having any issues with drowsiness, to do 3 milligrams a day. Can't hurt. I no longer recommend biotin because that can interact with some of the blood work like thyroid. Also, somebody who, for example, this is one example, somebody can go into the ER, get a workup for a heart attack, because and they look at the cardiac enzymes, it could actually affect the levels of cardiac enzyme and make it look like you're not having a heart attack when you are, and that's extremely scary. I don't see a huge difference with biotin. So it strengthens the hair and nails, but I don't see a big difference in terms of growth. So that's why I no longer recommend it. Okay, so now we're here with one of my favorite topics, which is androgenetic alopecia, also known as female male pattern hair loss. It's the most common type of hair loss. It is inherited, okay? So we found that, or we know that the majority of people with female pattern hair loss and male pattern hair loss have increased levels of an enzyme called 5-alpha reductase, which is not important, but basically it increases levels of that potent testosterone, which will cause miniaturization, thinning of the hair follicle. And this can occur as early as puberty. So just because somebody's a teenager doesn't mean that they can't have this genetic thinning. It can start here, and I see it a lot. It is progressive, so it's tough, and it's better to address it as soon as possible. In the male pattern, we see basically like an M-shaped type of thinning where you get, on the sides, And on the central and back of the scalp, you start to get thinning there. And it, as you can see, it gets progressively worse, and it could result in complete balding. Females, I do want to reassure you that we will not end up with complete balding. However, we will see diffuse thinning all over the scalp. And the most early sign of female pattern hair loss is seeing that widening of the part and widening of the central scalp. And then it starts to progress to the sides and the back, okay? So androgenetic alopecia, there's $1 billion industry in terms of the treatments for this. The problem is there's very few scientifically and FDA approved treatments. And we'll talk about what they are. There's many over-the-counter options. You see all these supplements around, but they're not well studied. They're not well known, the efficacy. So I kind of try to stay away from that. The goal of the treatment with androgenetic, as we know, it is, very progressive, is to slow down the progression, okay? And we want to increase hair growth. It's ideal if we can increase hair growth. Now, the FDA approved treatments that we have, which include Propecia, which include Minoxidil, which is Rogaine, they're better at slowing the progression of this, and slowing down the progression than inducing hair growth. And so maybe 20 years ago, this is all we had, and there was not many options, and it was tough because most people do want to see some improvement. So I'm just going to briefly talk about these FDA approved medications. Minoxidil, of course, Rogaine, it's available in 2 and 5%. I normally, for females, recommend 5% as well. And there used to be only a 2% in women's strength. Now there's a 5% as well. Now, the only issue with this, most patients will tell me, look, it's really difficult to remember to do this twice a day, even once a day is tough. So that compliance becomes an issue. I usually tell people, well, you know what? We don't complain about brushing our teeth twice a day or multiple times a day. So why don't we just make this, incorporate this into our regimen, our bedtime regimen, or our morning routine. But I do recognize, being somebody who uses it myself, it is tough to keep up with that regimen. One thing also, that the way Rogaine works is it increases blood flow to the hair follicles, stimulating that anagen phase of growth. And so what we see is, initially, when you first start using the first few months, you can have this, what we call paradoxical shedding, because it pushes out all these resting hair follicles so we can grow new hairs. So that's something that's hard to swallow for a lot of people, knowing that it can get worse before it gets better. Side effects, some people complain of increased itching or dermatitis, meaning a rash on the scalp. Especially in the solution, there's an ingredient in there called propylene glycol that a lot of people are allergic to. So if you ever find yourself really itchy from using Rogaine, switch to the foam, because it doesn't have that propylene glycol. That's just a little pearl. The other thing to know is that there's an oral minoxidil as well that's been used for a long time as a potent blood pressure medication. In women, in recent studies, they've also combined that with spironolactone, which we'll get into as well. And it's shown great results. The only issue is that first of all, some people complain of bloating because it's a blood pressure medication, and it increases fluid retention. So some people complain about bloating, but it could also affect the heart. So there's some issues with that. Rare, but it can happen. One of the even bigger issues, in my opinion, is that once you stop it, you're going to lose that hair that you grew back. So that's tough. Finasteride or Propecia. Again, it's a matter of taking the pill every day. A lot of people are not too excited about the side effects of sexual dysfunction, decreased libido, especially in the younger patients. They don't want to go there. And also rarely, but you can see mood changes, and rarely there could be some depression associated with that. Not common, but again, that can happen. So androgenetic alopecia, again, dutasteride is actually similar to Propecia. It's not as selective. It targets 5-alpha reductase, which basically decreases the conversion to that more powerful testosterone. That powerful testosterone, or those hormones, cause miniaturization of the hair follicles, and they cause them to become less dense and thinner. Spironolactone is also a medication that we use in women. Side effects, I mean, it's generally well tolerated. Most common side effects are menstrual irregularities, breast tenderness. Sometimes you can get headaches and fatigue. You tend to need to go on much higher doses, because we use spironolactone as a treatment for acne all the time, but this tends to be a higher dose, but it's still usually well tolerated. Laser light therapy, hair transplantation. Now, hair transplantation is expensive. It requires a lot more downtime. It's more, dramatic. And more recently, we've had PRP, which stands for platelet-rich plasma, platelet-rich plasmapheresis. And it's so nice because it's non-invasive. We'll talk about that in a second. But the main thing to know about all these treatments that I just went over is, yes, they're very good for slowing down the rate and slowing down the progression. You get some regrowth, but nothing too dramatic. Now, let's talk about platelet-rich plasma, or platelet-rich plasmapheresis. Basically, it's based on the premise that platelets are anti-inflammatory and promote growth. And we're able to obtain a high concentration of platelets in a small volume of blood. It's been used in orthopedics, wound care, now skin rejuvenation, and also hair restoration. So it has a lot of uses. When it comes to applying this to alopecia, there's been a lot of studies looking at different types of alopecia, most commonly the non-scarring alopecia. And our primary target, the best success is seen with androgenetic alopecia. And you really get the best results the first 5 to 10 years of onset. That's why it's always best to come in when you start noticing this. Interestingly, I've been surprised. I've had patients who are over 10 years who come in, and I'm like, okay, just so you know, it might not work as well. And they've been really surprised, and we've been very pleased. So, so that's really reassuring. And the nice thing is we do see some really, in these studies where they looked at the effectiveness of PRP with different types of alopecia, namely androgenetic, we've been able to see that it increases the hair follicle diameter. So we know that in androgenetic, your hair follicles become miniaturized to the point where they can become barely visible. It's called vellus hairs. They become barely visible. And so what PRP does is it stimulates that anagen phase, and thicker hair, it promotes that growth. So in these studies, they've been able to show not only increased thickness and diameter of the individual hair follicle, but they also see increased hair density per square centimeters in these areas. So that's really exciting. We're finally seeing something that we're able to see a good amount of regrowth within a few months. Okay, so that's really exciting. Other uses, alopecia areata. So I know we discussed, one of the most common treatments for localized alopecia areata. So just those small patches is usually injections with Kenalogs. And there's been studies that compare the Kenalog to PRP, and some showed that the PRP is superior to that. Some show that it's about the same, but you're less likely to have a relapse if you do the PRP, which is, again, it's exciting. It's not just about having that regrowth, but it's also about sustaining that. And again, telogen effluvium is great. I know we discussed about the most common treatment for this, of course, is addressing any medical like iron deficiency anemia or thyroid. However, if we rule out all medical and any other causes, sometimes 6 months to 12 months is just way too much for someone. It's extremely distressing. So I use PRP to help them get through this so we can try to promote growth even before that. And it's helped personally for me. It's worked really well. Traction alopecia, I've been very surprised. We've had some, not me personally, but I've had a lot of colleagues who have seen great results with traction alopecia, and they've seen some regrowth with that. So we're still studying that. Frontal fibrosing alopecia, it's a scarring type of a hair loss. I've been very pleased personally with my patients to see some regrowth and some, especially decreased inflammation.
I'm ready. I'm sorry. I don't like leave. I have to like. I'm OCD. I have to put it completely out.
Somebody needs to mute themselves. I don't know. I can hear somebody talking. In terms of one thing that I do want to mention.
Yeah, Courtney's calling. I'm using my phone for the meeting. I'm like, what do you?
Serena, we can hear you. Okay, great. Where was I? So one thing that's important to keep in mind with alopecia and the treatments of hair loss is that it's very common to have more than one type of hair loss. So it's very common for somebody with female or male pattern hair loss to also experience telogen effluvium or have alopecia areata at once. So, you know, that's something to keep in mind. And I find that in somebody like with frontal fibrosing alopecia, we commonly see that with androgenetic as well. And so the PRP does help with that. And again, like I said, it has a potential to produce visible hair regrowth within months. So that's fantastic. That's great news for us. It's natural. Many patients are very happy about it being, this is your own blood. This is your own product that's being used. And, you know, it's too much to use Rogaine every day. It's too much to, you know, they don't want to deal with the side effects of a systemic medication like Propecia. And it's well tolerated and less invasive than hair transplants. So now let's get down to the nitty gritty. What is PRP and how does it work? So you would come in, we'd have the patient sit down, and we would draw your blood. We have the special centrifuge, the Eclipse, and that's been a very special, it's shown really successful results with PRP, but it's a special centrifuge which spins the blood and it isolates these platelets. And we inject this platelet-rich serum back into your scalp, okay? That same day, the whole process, I have you come in, it's probably between 20 minutes to 30 minutes because you're waiting for the blood to spin. And then the whole process of injecting it into your scalp is only like a minute or two, very quick. So the protocol is monthly treatments. So one treatment every month for 4 months in a row. There's been studies that actually show better results if you do it consistently on a monthly basis versus like spacing it out, for example, for 3 months. Maintenance tends to be every 6 months. Some people, you know, 3 to 6 months, depending on the person. My patients end up being so happy that they finally see some growth that they end up wanting to come every 3 months. And it's synergistic. PRP works synergistically with other medications, with other female pattern hair loss medications, such as Minoxidil or Rogaine. So that's something that I always encourage patients to do more than one treatment to get the best results. That being said, a lot of people still only want to do PRP, and that's okay. But we do know that it does work better when you combine it with Rogaine. There was a study, which it was a little surprising, that compared PRP, somebody who's doing PRP with Propecia versus somebody, which is an oral medication, versus somebody with just Minoxidil or Rogaine, which is topical, the solution or the foam. And they actually showed better results with the topical Minoxidil than with the Propecia. So I thought that was very interesting. Common questions. Does it hurt? Anybody who works with me knows I'm the biggest baby. I hate needles. I hate them. But, you know, that's a price to pay to have some baby hairs growing out and starting to see some improvement. So a lot of us tolerate it. It's a little uncomfortable for a few minutes. I've never had anybody tell me that they don't want to get it done because it's too painful. We're very motivated people. Side effects after treatment. Some people can get mild headaches, tightness of the scalp that can last a few minutes. Sometimes it lasts a day or two. Definitely scalp tenderness. Again, it could last a few hours to 72 hours. In terms of, you know, what we tell people before getting treatments, we'll tell you not to take ibuprofen or Advil 48 hours before. Post care, we'll tell you same thing. We'll tell you not to take ibuprofen for 48 hours. And also I encourage people to go home that night and to go in a warm shower and give themselves a nice massage with the whatever shampoo that you use, and massage the scalp, because it diffuses to other areas of the scalp. So I very much encourage that massage. Oh, so now's the really fun part. And these are actual Windsor Derm patients that, you know, the before and after. So this was actually, normally we don't see, you know, we can expect to see results between some people, like in this case, this was after 1 or 2 treatments, I think. Most of the time I tell people 4 to 6 months, but this is after only 2 treatments. So we've had, you know, we're very pleased with that. And again, this is a younger individual, and we see, if you can see that we have that typical M-shaped pattern, but it's less pronounced after treatment. Another patient, again, young, within the first 5 years of hair loss, and we see nice improvement. This is after 2 treatments. So, and this is only PRP, by the way. Now this is women. This is a woman with PRP, and again, this was after 3 to 4 treatments. I see a significant difference here in the density. Another patient, as you can see, her part is significantly thinner after treatment. And again, another instance where the part is much thinner after treatment. So, in summary, I think it's very important if you have any type of hair loss to get evaluated by a board certified dermatologist. Number one, because we have the most training in hair loss to begin with. So it's not just about what do we use to treat, it's about, well, let's identify the cause. If there needs to be any workup, we'll do the workup. And then we'll come up with an individualized treatment plan to match your unique needs. So it's really important to get evaluated by that board certified dermatologist, and then we'll see if you're a good candidate. And I just want to thank all of you for taking the time to listen to me, to, you know, ramble on about hair loss. I'm open to any questions. So I know there was a question that was submitted on, is hair loss genetic or inherited? And it is. It depends on the type of hair loss, but as I referenced earlier, androgenetic or female or male pattern hair loss is in fact genetic. So that's important. Alopecia areata, multifactorial, but can be genetic as well. Any other questions, guys? Oh, there's questions in the chat. Okay. Chat. Okay. So I'm not ashamed to say I'm technologically not as great as a practicing dermatology. So I am going to ask for help. 1 second. Let's see. How soon can we expect to see results from PRP? Depends on the person. For some reason, I find that men I see results sooner than females. So I would say anywhere around, you know, after 2 months, on average 4 to 6 months. So there was another question. How fast can I get an appointment with you? Just call. We'll do our best to accommodate you. We will. So that's that. And you could actually mention that you watched my talk. So that's a few brownie points for you. Xeljanz for alopecia areata. So that's tough to get in the private practice setting. It's an immunosuppressive agent, and what we know about it is there's been very promising results with that, but it's temporary. So as soon as you stop using it, you tend to, within a few months, go back to your original state. And that's kind of the same thing for any systemic, like prednisone or methotrexate as well. So it's a little bit challenging, but that doesn't mean it can't be done. I'm going to see if there's any more chats here or any more questions. Okay, here we go. All right, so let me see. I'm just making sure that I actually answered all of your questions. Propecia, any side effects for females using Propecia? Well, I just want to preface this by saying that I tend to only prescribe Propecia for postmenopausal women and similar side effects. For treatment with PRP for men, you said it's 1 treatment a month, then maintenance 3 to 4 months. Actually, it's maintenance every 3 to 6 months. Is that until desired result is reached? That's actually a good question, because after 6 months, after 6 months from your first treatment, I have you follow up with me, and we take really good baseline pictures. We're able to compare. And in addition, you'll be able to let me know whether you think it's improved or not, but we have pictures to help. And at that point, we see if it's effective or not. And if it's not effective, I'm not going to tell you to waste your time. Then you just don't come back for maintenance. I'm not going to have you come in, 3 to 6 months if you didn't see much of an improvement. I hope that makes sense. When typically does hair thinning occur due to age? If you mean which the most common type of hair loss due to age is female or male pattern hair loss, which is androgenetic, that tends to happen postmenopausal. So after the age of 60. Interestingly, I've been seeing it earlier and earlier. So it is interesting, but yes, it tends to occur postmenopausal and basically 60 and up. I'm sorry, maintenance after. Is there a reason men tend to see results faster than women? I'm speculating maybe it's because their hair is shorter. I want to know the answer to that. I'm not sure. Well, their hair is shorter, so I mean, it's a lot easier to see in shorter hair, the difference, but I don't know. I don't know why. That's just been my personal experience. Are any of the treatments covered by insurance? Unfortunately, PRP as of now is not covered by insurance. It's considered cosmetic. Is there a time limit to how long this will work? Okay. Is there a time limit to how long this will work? Like if you have been losing your hair for 10 plus years, will this help? Ideally, it's most likely to be successful within the first 5 years, even up to 10 years. I have plenty of patients who have had hair loss less than 10 years. It's less likely to work, but it can work. It's just less likely. So it is a financial risk, but it can be done. Do you find that Propecia causes more hair growth than topical Minoxidil, or would you consider it more of a? I would consider Propecia more as a hair loss stabilizer as well. Although we do see a lot of the improvement that we see with Propecia is usually seen initially in the beginning, and then it maintains itself. But it's better at stabilizing that progression, or halting that, not halting, but slowing down that progression. I'm pretty sure that I answered all of our questions. Anybody else? I'm just looking for more questions. I don't see anybody, oh wait, it says 3 more messages. That's a great question. Somebody asked, is this approved for anyone under 18? I actually have handful or even more of patients under 18 that I do PRP, and it works really well for them. So yes, we do it for patients under 18 because we start to see that female or male pattern hair loss after puberty. Okay. So, is PRP a good treatment for thinning hair for women with hormonal imbalances due to PCOS? Will the results be permanent? That's a great question. PCOS, polycystic ovarian syndrome, is a condition in which you could have several things going on. One of them being, difficulty to get pregnant. It can manifest as acne, excess hair, like excess facial hair. We don't recommend it as using it as a treatment for PCOS because we're not addressing the underlying issue. So we do recommend you getting treatment by your OB-GYN for that. Okay. I think that's it. Okay, guys, thank you so much for listening. And I'm always around if we have any questions and you want to talk more. All right. So we have to make sure that the recording saves. So wherever onto the desktop. So